Okay, let's go ahead and get started, everyone. So good afternoon, everyone, and thank you for joining today. My name is Steve Rhodes, and I'm the co-CEO of Arrow Health. I'm very excited to introduce our partner, Alan Dade, to the presentation today, as well as Josh. We at Arrow Health sought out Alan Dade as a partner for our clients because they kept asking us, how do I participate and succeed in value-based care? One of the biggest issues that we see with value-based care participation is its reliance on complex financial models instead of direct provider enablement. And this makes it very difficult. Plans have introduced intricate reimbursement structures with numerous attributes to manage, utilization and quality measures, frameworks that require providers to navigate conflicting metrics, and just analyze vast amount of claims data to participate in the value-based care programs. It's a process that often overwhelms our customers and our providers, and it makes it difficult for them to focus on improving care. So given the challenges that we're seeing in the market and we're hearing from our customers, we found a market leader to assist our clients in understanding and how to succeed in value-based care. With that conversation and observation, I want to turn it over to Josh and Alan Dade, and excited to have this organization help our clients lead through this. Thank you.
Steve, thank you so much, and thank you all for being here and joining us on this conversation. And I'm happy and excited to talk to you all about value-based care today and how Aledade can help you perform in value-based care. My name is Joshua Dumas. I have the pleasure of serving as the Director of Practice Management with Aledade. And today we're going to talk about three different things. One being the tenets of value-based care, ACOs, and the physician-led ACO model in a primary care setting specifically. And then we're going to talk a little bit more about how primary care organizations can prepare for and manage downside risk in value-based care arrangements. And then before we wrap up for questions, we'll kind of speak to new and revised rules and regulations for value-based care in 2025. So what is value-based care, and is it better than what you're doing right now? At the end of the day, value-based care reduces unnecessary spending and rewards preventative care. In an effort to curb healthcare spending in the United States, CMS rolled out what's called the Medicare Shared Savings Program, or MSSP, in 2012. Since then, MSSP ACOs have generated more than $21 billion in gross savings for Medicare. Hearing that, around $4.5 trillion are being funneled into American healthcare spend right now. 1.1 trillion of that just going to waste. So how can we solve that at scale? And that was what the federal government has committed to. They have stated that a goal of every single original Medicare beneficiary going to an accountable care relationship by 2030. Today, Medicare enrolls around 1 million beneficiaries per year in accountable care. To reach their own goal, Medicare would need to enroll around 3 million people in accountable care each year between now and between 2030. So this is growing and this is happening. So let's talk a little bit about the history and where this is going to go. Introduced by CMS in 2012, MSSP fosters collaboration through accountable care organizations, or ACOs. An ACO is a group of healthcare providers, such as doctors and hospitals, who voluntarily collaborate to coordinate and improve the quality of care of a defined patient population. And those ACOs that achieve cost savings while maintaining high quality cost share in those savings will continue to receive just more of those shared savings, as well as the fee-for-service revenue on top of the work that they are already doing. MSSP offers several risk tracks representing varying opportunities for shared saving and shared losses, which we'll cover on a little bit later in this presentation. And as you can see in this diagram, when you have the ACO working with information, data, and analytics, along with practice management and patient management support, and you have your payers that are helping funnel the funding of this work, all of this helps create lower cost care to create savings for both the payers, the ACOs, and its members. So what are the program requirements for the Medicare Savings Program? This is actually one of the most tried and true programs that Medicare has today. So program requirements include robust care coordination infrastructure. Well-established processes and systems are needed to coordinate patient care within an ACO. This includes mechanisms for sharing patient information, managing transitions of care, ensuring collaborations among healthcare providers. You also need data sharing capabilities because to be successful, ACOs have to have the ability to exchange health-related information among participants, participating providers, and with other entities such as hospitals and pharmacies. You have to almost play quarterback between so many different entities, and being able to pass along that data and information seamlessly is essential. At Alidade, our app does a lot of this heavy lifting because we cannot afford to have errors happening through not having these processes for data sharing capable at scale. Demonstrated cost savings and quality improvements. MSSPs requires ACOs to demonstrate tangible evidence of both cost savings and improvements in the quality of care. These outcomes are crucial for achieving shared savings. These are demonstrated by showing cost reductions for attributed beneficiaries against predetermined benchmarks, or meeting or exceeding a set of quality performance measures and improving patient outcomes, such as reducing hospital readmissions. An MSSP offers varying risk tracks, representing ranges of risk and reward. ACOs choose a track that's aligned with their risk tolerance and commitment to value-based care, shared savings, also known as upside risk. And that upside risk is the potential for financial rewards that ACOs can earn if they successfully reduce healthcare costs while meeting or exceeding quality benchmarks. Shared losses, also known as downside risk, is the potential for financial losses that ACOs may face if they fail to manage costs effectively and don't meet the quality benchmarks. Your upside risk models are obviously and clearly a safer option, but downside risk arrangements offer more potential for cost savings for providers and are a key part of the road true to value-based care. At Allidated, we take an active role in placing practices into ACOs that allow participants to confidently take on more risk for more reward. And these decisions are reviewed annually with input from impact analytics, performance, and policy teams that are constantly analyzing the value of the risk and reward of the contracts that we're participating in. We made up around 50 or so percent of all ACOs in the 2023 MSSP program. A majority of these ACOs were in tracks E and enhanced. This enables our practices the potential for more rewards, with Alidade covering 100% of the downside risk. Is your organization ready for the accelerating move to value? Because the move to value is happening. The federal government has committed that every single original Medicare beneficiary will be in accountable care relationship by 2030. Today, 1 million beneficiaries per year are being enrolled by Medicare into these plans. So to reach their own goal, like I stated before, that's 3 million people in accountable care every single year for the next 10 to 15 years. Allidated has added more than 450 primary care practices, including 60 health centers to its nationwide network for 2023, the most value of any value-based care practice network. And that is why choosing an experienced partner matters. We have the experience and the systems to track and support practices of all sizes. And our company continues to be the largest network of independent primary care in the country, with more than 2 million patients covered by more than 150 value-based contracts across Medicare, Medicare Advantage, Medicaid, and commercial payers. Allidated works with more than 1,500 primary care practices and health centers for more than 1,000 practices in 2022, including more than 5,000 physicians and 15,000 clinicians across 45 states and DC. So thanks to our product and technology, we can grow further, we can reproduce at scale all of the outcomes that we've delivered for our individual practices and our patients. And the more practices and medical spend that we continue to add under our umbrella, this allows us to minimize our variances, to utilize economies of scale, and really be able to share more knowledge and data and best practices and increase the predictability of the performance of our ACOs. But risk is an interesting word, and minimizing risk at the end of the day is hopefully what we are all here to do. The most important number that I want you all to take away is that well over 90% of our MSSP ACOs received a bonus payment last year. Just to compare, this isn't on the slide, but it is true, and I do want to make sure I say this. Only 68% of the rest of the MSSP ACOs received a bonus. So over 90% versus that 68% in the exact same program. And that average payment was around $200,000. But again, with risk, that fear has caused thousands of eligible primary care practices, clinics, community health centers to miss an amazing opportunity to join ACOs and increase and diversify their revenue while enhancing the delivery of quality coordinated care to their patients. But it shouldn't be scary. As a trusted resource for physician design tools, expert support, and a proven model of care, we're committed to helping your organization move to enhanced tracks of the MSSP and take part in value-based contracts with commercial payers and Medicaid with confidence that you deserve. When you use our recommended solutions, we safeguard your practice from risk, advance and enhance tracks as soon as possible with 100% protection against your downside risk. And as the national shift towards value-based care speeds up, trying to avoid risk only puts primary care organizations at greater risk. So by taking advantage of the Alliday commitment, independent practices, clinics, CHCs, community health centers can secure their future with customized tools, expert guidance, and this scaled model of success. And again, specifically in value-based care, we really, understand that difference allows a flexible way to incentivize our physicians and improve quality care and add another option of way to meet the financial standards that our physicians deserve to be met. In upside risk only models, ACOs receive shared savings if they succeed in managing costs, but they're not financially liable to return any money to the payer if they spend more than the target amount, right? But on this downside risk, you're getting the higher percent of shared savings if the ACO successfully manages costs. And that is why participating with an ACO that has a record of success, even when participating with the downside risk models, to give you a better chance at success. In healthcare, you get what you pay for. And primary care must recognize the business case for addressing social determinants of health. And the effectiveness of the fee-for-service system is reliant on mission-oriented clinicians who go above and beyond CPT codes to improve health outcomes. With a growing understanding the last decade, I think we all now have some insight into the role of social drivers of health. Primary care recognize what they do within their clinic's four walls just may not be enough for patients to improve their health. To have an effect on health-related social needs, clinicians need to participate in community initiatives that connect with patients and services. And social drivers of health are growing in areas of focus, not only for ACOs, but for primary care at large. These initiatives focus on fighting insecurity, promoting healthy eating through food banks and community gardens, targeting transportation support to the primary care office or pharmacy, offering offsite services like health fairs, blood pressure initiatives at barbershops, free clinics, or creating community networks and other community partnerships related to social drivers of health. You can see on the slide how much money and how much financial opportunity remains untapped just from addressing these non-medical things. And I just wanted to call out that you can see that circled $93 billion in healthcare costs, in excess healthcare costs due to health disparities. So those different interventions that I spoke to, they don't add up to $93 billion. So having a partner that recognizes the importance in the business case of addressing this work, though not clinical, is important of doing the work upstream and financially for the ACO itself. CMS introduced the MIPS value pathway, and it has plans to sunset the traditional MIPS. A few years ago, CMS started with an idea to try and decrease the burden of MIPS by consolidating it. And this is what came up with what is known now as the MIPS value pathways, or MVPs. The MIPS value pathways are a reporting option that offers clinicians a subset of quality measures and activities relevant to a specialty or medical condition. They offer more meaningful groupings of measures and activities to provide more connected assessment of the quality of care. Starting in the 2023 performance years, MVPs allows you to select, collect, and report on a reduced number of quality measures and improvement activities compared to traditional MIPS. One thing to note is that you would report the complete promoting interoperability measure set, the same thing reported in traditional MIPS. So for MIPS eligible clinicians not currently in one of our ACOs, MVPs may be an easier path for data submission in 2024. And you can register for an MVP in 2024, beginning April 1st through December 1st. And this is one of the key differences between MVPs and traditional MIPS. And frankly, the MVP registration is necessary. The other thing to understand is that CMS plans to make MVPs mandatory in future rulemaking, sunsetting the traditional MIPS. So for those who continue on this MIPS track, this is going to be the path forward anyways. So let's talk a little bit about some keys to focus on. At their essence, all value-based care contracts are arrangements between payers seeking to partner with provider groups aligned into accountable care organizations in an effort to improve the quality of patient care while reducing the total healthcare expenditures for their assigned patient. Annual wellness visits as prevention-focused visits can really help support physicians, NPs, PAs, whoever the provider is, ensuring that attributed patients are being assessed for their chronic conditions. They're being provided with access to preventative screenings, and they're receiving regular education about their personal risk factors. These conversations with their providers can help patients avoid the clinical emergencies and identify treatable conditions and diseases before they actually become acute emergency problems. And additionally, MSSP beneficiaries who receive an annual wellness visit, they are literally 13% more likely to be attributed to a practice the following performance year. Shared savings distributions are based on a total attributed patient population of performance. So an increase in that attributed patient population when paired with this performance in value-based care leads to a massive opportunity in shared savings. Transitional care management workflows are critical. An established process can help prevent readmissions. On average, as you can see, 14,000 saved generated for each prevented readmission. We have integrated timely data for patients recently in the emergency room, hospital, skilled nursing facility, with easy to use post-discharge workflows to embrace our vulnerable patients after they have an escalation in their care. Because once they leave that hospital or once they have an acute moment, at that moment, they are the most important patient. So having these workflows to ensure that they have what they need to prevent them having to step foot back in that emergency room is so unbelievably important. So these post-discharge workflows enable teams to provide the valuable and timely follow-up care to patients. engaging primary care resources to prevent readmissions and improve care. Transitional care management, or we call TCM, includes services provided to patients that are transitioning from inpatient to a facility or facility to home. And ED visit follow-up is a primary care service that involves calling these patients after they go to the ED to address or coordinate any of their needs and schedule time or schedule their follow-up care with those that they need to schedule their appointments with. And these calls allow you to demonstrate concerns for patients, provide triage support, even prevent another ED visit. The call is also an opportunity to identify a patient's barriers to getting care at the PCP and provide education around same-day hours and after-hour clinic services. Many of times a patient will go to the ED simply because they didn't know if their office was open. The ED is closer, and how quickly could a call mitigate that from happening again? Advanced care planning is necessary. So CACP, or Comprehensive Advanced Care Planning, offers an additional layer of support to patients that are facing serious illness. $1,300 average incremental share of revenue per MSSP patient enrolled in a comprehensive advanced care planning program. Simply having the appropriate conversations, having the appropriate paperwork, and having the around full management for the entire family of patient will help not only reduce stress, anxiety, depression during a potential bereavement period, but also save the patient and the practice and the provider so much in potential medical costs. When we deliver CACP, the cost of care for patients reduced by an average of almost $300 per member per month. A survey of physicians found that 92% of physician practices felt that our CACP team of experts provided beneficial service to patients. We connect patients with advanced chronic kidney disease to a specialized RN-led kidney care management program with Village Health. We prevent patients from crashing into dialysis, thereby avoiding clinical and financial disruption. There are substantial benefits to this program, including cost savings averaging from $5,000 to almost $14,000 per member per year, a 32% decrease in hospitalizations, or a 20 to 45% average reduction in the total cost of care for that patient. Focus area 4 is selecting an ACO partner that invests in your success. Your organization has unique needs. Your ACO should invest in your needs with the right tools and resources. Our model works when you focus on the core 4 of objectives, but you stay patient-centered, evidence-based, complementary, you advocate for regulatory guidance, you are great partners and you are flexible. That creates a partnership and gives you confidence that you have a partner that is dedicated to your long-term success in value-based care and is competent to get you there. So why join Alidate now? Our model works. When you focus on our objectives, what we consider the core 4, and you deliver AWVs, improve your risk score adjustments, and get ahead of ED and hospitalization rates, you end up with results like we do in our enhanced ACOs. Year over year, the pinnacle in performance continues to be participating in an enhanced ACO, both for health centers and for Alidate. Alidate's ACOs retain 75% of earned savings to split with practices, and also exempts participants from MIPS reporting because from being an advanced alternative payment model. So get a head start on your performance here and work with us. And just for you all listening to me speak with you all for the last few minutes, and thank you all for listening, we have an exclusive offer for you. If you join Alidate and combine our EHR revenue cycle assessment with Suno AI, we will offer them to you both just for joining Alidate. And to give you some more information, our EHR revenue cycle assessment is essentially an opportunity for us to evaluate your current operations and your EHR settings and workflows and offer solutions that will streamline your workflows, increase your productivity, and improve your financial performance. Almost a $10,000 value just for you. And Suno AI, it's ECW users can receive up to 200, all of you will receive up to 200 Suno AI visits for every eligible physician per month when you join Aledade. Almost a $5,000 value for you all being here. And now this will be the time to open up for questions. Thank you all for your time.
Josh, thank you. Great presentation on value-based care and how Alidate can help take the work out of participating in this complex reimbursement model. As I mentioned at the start, our goal was to ensure that our providers are not stuck navigating endless data while being held accountable for outcomes they couldn't influence. And I think Alidate is a great resource to get started in these value-based care programs. So let's take a look at what questions we have in here today. Let's see here. Savings revenue with Alidate. That's a first question.
The question was, what is our savings revenue?
I believe that's what they're asking, yes.
I hope this answers our question, but I will go to the appropriate slide for you. $538 million of MSSP savings was distributed to our ACOs.
Wow, that's a lot.
Yes, absolutely.
Another question. How does a practice get started?
That is a great question. And we will be, I believe, getting a list of those that have participated here and where you will get some information from our wonderful folks to follow up on this, and if you want to participate in the opportunities that we have ahead. So there will be some information that is that will be available to you. You can visit for more information at alidate.com, and there is a tab on how you can join us that does also give some information as well. Thank you.
Great. Can you explain a little bit on how Alidate works specifically with ECW? What data is utilized and how?
Absolutely, and ECW has been an incredible partner for us so far, where the majority of the practices that we are working with are ECW users. And the way that we interoperate with ECW is very bidirectional. And a lot of we are not in EHR. And I do want to, kind of separate the two. Right, so not being an EHR, but there's still so much data that is coming in and out of your EHR that may or may not be easy to kind of siphon through. All the work is being done in your EHR, but actually being able to understand what to do with that data and what does that data say you have to do tomorrow in order for you to succeed a year from now is how we partner with ECW. So our app and our information takes all of that complexity, the information that's going into your data with ECW, the information that's outside of ECW, and making it all make sense so that your providers know exactly who are the patients that are most important to see so that you can succeed most efficiently in value-based care. Hopefully that answers.
I understand, Josh, that this information is actually pushed to the right chart panel as far as gaps in care and things like that. So keep it within the provider's workflow, which is key.
Absolutely.
Great. All right, let's see if we have any other questions. Looks like that wraps it up for right now. Again, Josh, thank you for the information, not only globally on value-based care. This model is here to stay, everyone. We know that.
Absolutely.
The earlier you can begin participating, the more successful you will be. Arrow Health is here to help you with navigating how to access data and providing data to partners like Alidate. But I just want to make sure that everyone understands this is complex. And it's very important to find the right resources to work with so that you succeed. And if a resource like Allendale that's guaranteeing some upside and reducing downside, that sounds like a winning formula. So congratulations, Josh, on the success of Allendale. Thank you everyone for joining. This has been recorded, so you'll be getting a sample of this in an email. And don't hesitate to reach out to us directly here at Arrow Health if you have additional questions. Thanks, everyone.
Thank you.